In this video, we will go over what to expect with a basic monofocal intraocular lens. The first thing to know is that this lens can correct for approximately half of the equation of a prescription. That is, the first number in what is commonly three numbers in a prescription for corrective lenses written by your eye doctor. In an example, this is the number that it will correct for, but not these two numbers. The first number denotes the spherical power of the glasses, and the second two numbers define the power of the astigmatism correction, or the cylinder power, and the axis or the rotation of that power. Some may ask, I don't see the other two numbers, so I must not have astigmatism. Well, this is not usually true after the cataract is removed. You see, astigmatism is the sum of the warpage in the cornea in addition to the warpage inside the cataract. These are the two refractive elements in the eye that focus light. You may not currently have an astigmatism in your glasses prescription, but usually when the cataract is removed, the corneal astigmatism shines through, and often you will end up with an astigmatism after cataract removal, since the cataract's astigmatism sometimes counteracts the corneal astigmatism naturally. And we had discussed earlier that the cornea is almost never perfectly symmetrical or spherical. In practice, almost every patient has corneal astigmatism. At least 99% of patients, some much more significant than others. Astigmatism can be corrected with a special type of lens called a toric lens, which we will discuss in the next section. Let me demonstrate again the effect of astigmatism on an image with a flexible mirror. I'd like for you to pay attention to this ring of light. If I put slight pressure on one axis, in this case 180-degree axis, you can see that the ring will become an oval shape. And likewise, if I were to apply the same pressure in the other direction, you obtain another oval shape stretched out from up to bottom. And if we compress that even more, this would represent a higher power of astigmatism. Because we all have some degree of astigmatism, we should be prepared to wear glasses for our best corrected vision at all distances. The second decision we must make if we pursue a basic monofocal lens is to choose a target. Remember, the monofocal lens is one power and can focus light from one distance only. For other distances, you will again need to rely on glasses or contact lenses. There are no wrong decisions, and it is usually determined by determining what the patient's profession and main pastimes are. For example, if you are a pilot, you would rely on your distance vision, and so you would pick distance for the target. But if you are an avid reader of novels and spend the majority of your day reading books, then you would be best served choosing a near target to be able to read relatively well without reading glasses. Or you may wish to choose what you were given naturally in life, such as to remain nearsighted. Most patients choose to set their basic monofocal intraocular lens to distance target. This works well for most people for two main reasons. One, as we age, we may find it easier to misplace our glasses or break them, and we must realize that we are very vulnerable if we are nearsighted without glasses. This would mean that we would not be safe to walk around and avoid obstacles such as stairs or drive our cars. So safety is a main issue. Two, it is much cheaper to buy over-the-counter reading glasses for the patient that chooses the distance target than it is to buy distance correction glasses for the patient who chooses the near target. You may be familiar with the difference in cost. To give you an example, a pair of reading glasses costs $5, and a pair of distance glasses costs at least $200, but can be upwards of $800 depending on the options you choose. Lastly, We are often asked about monovision using the basic intraocular lens. This is a tricky visual scenario, and in my experience, patients either love it or hate it, and unfortunately, it is more of the latter. Monovision is where one eye is set for distance, while the other eye is set for up close. Usually there are at least 2 diopter difference between the 2 eyes. This creates 2 issues. The eyes now see different sized images, and it may be hard for the eyes to work together, making it hard to judge distances. Most surgeons have had patients ask them for monovision because they had tried monovision contact lenses, but often both the surgeon and the patient regret this choice. With a contact lens, you can take it off for activities where you require good depth perception. However, when you set your eyes to be different after surgery and then you decide to wear glasses to correct the difference or to correct astigmatism, you effectively build a telescope with the lenses and your eyes such that the image size disparity is even more pronounced. This is the experience of my wife, whose eyes are 2 diopters different due to a retinal detachment repair with a scleral buckle. And it is very difficult for her to judge distance when driving. It is often hard for her even to catch a ball despite being 20/20 in each eye individually. I ask that you consider monovision very carefully and only choose this option if you are born with monovision. You must consider your safety, especially when driving, where you must also consider the safety of others on the road. This concludes our discussion of the basic monofocal intraocular lens. The rest of the videos build on these concepts as we add more options to this basic lens to enhance your vision.